India. Uh, I would like to call upon Dr. Rahul Jain. He is considered rheumatologist at Narayana Hospital, Jaipur. We have speakers Dr. Varun Dheer, Dr. Kumaro Yamoka, and on virtual Dr. William Dixon. Dr. Sajjan Chanai, who is considered rheumatologist at KMC Manipal, will be chairing with Dr. Rahul Jain. I call upon Dr. Varun Dheer to deliver the talk on Indianizing RA treatment, future of RA treatment in India, precision or treat to target. Dr. Varun Dheer, please.
Thank you, Shiva. Dr. Rahul. I think Sajjan will be joining us. Good evening, ladies and gentlemen. So, starting off straight away, I've got 15 minutes, and the topic is about Indianizing treatment and deciding between treat to target or personalized RA medicine. So, 425. Yes. Yeah. So I think what the way I'm going to be proceeding with this talk is just first talking about a personalized, first talking about treat to target and then personalized RA medicine and what are they, and then deciding about what where do we stand in India regarding these. So this is the format of the presentation basically, that essentially I'm going to start with talk about the concept of treat to target, proof that it works, how to implement and what are the challenges, and then talk about personalized medicine, what is the concept of personalized medicine, and volume? Okay, thank you. Sorry about that. So first, in personalized medicine, I'm going to be first talking about the concept, then talk a little bit about studies which have taken place with this concept, and then randomized controlled trial based on it. So what is treat to target? Now treat to target is not a strategy that that any of us needs to be told about. It's a strategy which stresses on keeping a target and making a plan for it. So I think one of the important, if you would say a synonym for this would be a tight control strategy. And essentially this is a graph from one of the articles on, apologies, one of the articles in Nature's Review Rheumatology in 2019, which talks about the fact that, you know, the first step is to identify a target. And I think this emphasis has been there for a long time of using a formal disease activity assessment rather than the usual that whether the patient is doing well, and moving on to, you know, having a scheduled time visit for the patient when you call the patient for a review, finally to, you know, deciding at every follow-up visit whether you are close to achieving the goal or whether you are on the path for the goal, and finally make the crucial part, which is the action part based on this plan and this assessments, whether you have to make a change in treatments. Now the change in treatments, as has been written here, could be multiple. The change in treatment could be in terms of when you're on conventional synthetic DMARDs, whether to just raise the dose of conventional synthetic DMARDs. We are all aware that methotrexate requires multiple visits to achieve and monitoring visits before you achieve a dose of like 25 milligram per week. Most of us would not start at 25 milligram per week directly. We would be more comfortable starting in steps and monitoring the patient. Similarly, sulfasalazine, as we are all aware, and probably to some extent in leflunomide as well. Many people would start at 10 and then go on to 20. The second part can also be obviously to change the route of administration, especially if you feel that we know that this is specifically for methotrexate, where there is some evidence to suggest that you get higher methotrexate concentrations if you use a parenteral route of administration. Then, you could add on glucocorticoids. This is the controversial part of this treat to target, because as we'll discuss, adding on glucocorticoids in many settings there has been increasing concern that it is good as a bridge therapy, but what's the benefit to risk ratio on long-term treatment is still, most people would not accept long-term treatment as a routine part, unless of course there are reasons for it. And of course you keep adding or changing conventional DMARD before you finally reach combination conventional DMARDs, and finally with the failure of conventional, if you have a failure of combination conventional synthetic DMARDs, you go on to either biologics, and of course in our country, and then to JAK inhibitors if you are probably an insured with the new FDA recommendation with JAK inhibitors only after you failed TNFIs. But in our country probably it will be slashed, because obviously many of the patients don't afford biologics. And how is treat to target different from what we usually do or have been doing? So, the usual aim, I think the most crucial part is the first point. You can have, what treat to target suggests is that the aim should not be patient comfort alone. Because majority of our patients, and there was one study which looked at patient comfort, and patients even having disease activity might be pretty comfortable, variety of reasons. Many patients get used to the stiffness, they feel that this is a normal, and I think that's the way God has all made us, that we adapt to any situation. Patients with chronic disease activity having early morning stiffness for 1 hour, having 3 to 5 or 7 joints active, would still say that they are fine. And that's why treat to target stresses on a formal activity score rather than just asking the patient, how are you? And I think the fact is that whereas in usual practice or a flexible practice, you would say the patient comes and, but in a treat to target, you make a plan, you make sure the patient understands. You do definitely a formal joint count is much more emphasized in a treat to target setting, unless of course you're using something like Rapid 3, which some people have proposed as an alternate. And obviously you do expect that your modifications in treatment would be much higher and much more aggressive treatment in treat to target. Now, treat to target, although it may be something which has been emphasized in the rheumatoid arthritis for the last decade or so, but it's not so for internal medicine as such. And physicians are pretty clued into treat to target for diseases such as chronic diseases such as diabetes or hypertension. What is the difference between these chronic treat to target in these diseases and rheumatoid arthritis? Obviously, the most, I would say, striking difference is that rheumatoid arthritis is a symptomatic disease, whereas when we talk about treat to target for, like, say, hyperlipidemia, hypertension, or diabetes, all of these are silent diseases, and that is the most important difference. This was a paper in 2014 which did suggest, if you read, that the evidence for tight control is relatively weak in the long term for treat to target in rheumatoid arthritis. I guess what the author did mean to say is class 1 evidence, but we have reasonable evidence which may not be a randomized controlled trial evidence of a long duration, but we do have reasonable evidence that yes, treat to target does work. But I'll tell you what are the problems with that in just a minute. So this was one of the pivotal studies which is emphasized as which gave impetus to this movement. This was a Ticora study published way back around 15 years back, and which talked about tight control. And they had 2 arms basically. One arm in which they saw the patient monthly, and they had a treatment protocol in which they moved on quickly to starting with monotherapy of sulfasalazine, moving on quickly to combination synthetic DMARDs, and then escalating methotrexate in that combination till they escalated and did a change in treatment if the disease activity score was not matched. Whereas in the usual routine management, they saw the patients every 3 months. There was no formal plan. It was up to the rheumatologist whether they would change the treatment or things like that. And they did find that there was a significant difference at the end of almost 1.5 years, and you can see this gap. This is on the y-axis is the disease activity score, and what they have emphasized is that the disease activity score, you can see almost a difference of around a dash of 1 between these 2 groups, and you can see that the tight control patients were much higher, much better in terms of tighter control. So just emphasizing something, I guess, which is intuitive when we teach school children that if you plan for something, you get better results. And that is something I think both leadership talks talk about, that plan for this thing and better than firefighting, but proven in rheumatoid arthritis. Interestingly, the adverse effects were not higher in the group which received tight control, and this is important to emphasize that if you look at the patients assigned usual care and intensive group therapy, actually speaking, there were by a play of chance, probably higher deaths and higher problems which were faced in the routine care arm. Obviously, would not be statistical significance. So, how to implement treat to target in the clinic? That's an important part. This is again I've taken this picture from a review article, and again, I don't need to tell rheumatology audience about the steps. But essentially, if you see here, this is from one of the from Europe. This paper was authored from Europe, and you can see here that straight away after methotrexate, they're talking about going to biological DMARDs or JAK inhibitors. Actually speaking, and I've written the Indian context here, or probably a more context based on on conventional synthetic DMARDs, you would reach this stage only after around 12 months. Because in most of our practice, you would reach a methotrexate high dose by let's say between 3 to 6 months. If you reach 25 milligram of methotrexate at the most by 2 to 3 months, you wait another 3 months, 6 months has gone by, you shift over to combination synthetic DMARD, you add on, maybe some people might add on leflunomide, over sulfasalazine, some people might add on sulfasalazine, hydroxychloroquine, obviously most of us would add on either ab initio or at any time, because for us that's not a very big choice. And then at somewhere around 12 months, with this therapy you decide your patient is not doing well, and at that time you offer your patient biological DMARDs or JAK inhibitors. Obviously at that time this recommendation was made. The oral surveillance study was not out. The oral surveillance study, obviously, as most of you would know, was a landmark study, which was a post-marketing surveillance phase 4 study, which has now conclusively proven that there are some risks with JAK inhibitors over and above TNF inhibitors, and so therefore leading to FDA labeling change of using JAK inhibitors only after after a failure of TNF inhibitors. So it was not or, which it suggested here. Probably in most of the developed countries, they have now implemented biological DMARD followed by JAK inhibitor, whereas obviously for us it would remain the same for obvious reasons. Most of our patients are uninsured. JAK inhibitors would be much more lighter on the pocket. Biologics, even the most generic and biosimilars would still remain very expensive. Now, the biggest point about what we are unclear about treat to target, and that is from, I think most of us feel, is that where is the tipping point? Now, every therapy has a tipping point. We know that hypertension has a J-shaped curve. You keep treating hypertension, but once you go below a certain limit, once you start getting the systolic and diastolic BP below a certain limit, the mortality actually increases. And therefore, in rheumatoid arthritis also, we keep asking that where is the tipping limit? So you can go on to very aggressive therapy. You keep a kind of a, let's say a focus on disease activity, and you keep on introducing new and new drugs. You give the patient JAK inhibitors. You give the patient one biologic, doesn't work. The other biologic doesn't work. And so at some stage, the question is that at some stage, are you tipping the balance and going towards more adverse effects or a chance of higher mortality or a poorer outcome once you start treating a patient with that? And this is a very difficult, I don't think we'll have the answer for this. And these answers are very difficult and I guess also to some extent personal, because a lot of patients might say that they're willing to take the risk because their quality of life is so bad. At the same time, there might be patients who are unwilling to take the risk, even a slight amount of risk. So just talking in terms of statistics won't do here, even if we have a study. So I think again emphasizing here that the short term versus the long term trade-off is the main thing. That are you looking at the short term, are you looking at the long term? Short term, the patient with combinations and with change of therapies is more likely to have adverse effects, obviously. If I don't expose my patient to a lot of drugs, the adverse effects are definitely going to be low. only if I give my patient TNF inhibitors or rituximab or JAK inhibitors, am I going to see out of 100 a few patients who have those adverse effects. But at the same time, I would be doing a service to the remaining patients. But so that is the trade-off which we all have to see. And sometimes patients just look at the short term, and we have to look at the long term. But again, there are some people who might say that who am I to decide for the patient? You know, who am I to say that you have to look at the long term or the short term? It's ultimately the, as we talk about, it's the patient's kind of wish or their life, their body. So I said very complicated issues, but we are kind of, these are issues which remain in treat to target. How much time do I have? Sorry, huh? 3 minutes. That's all. So, okay, so in personalized medicine, I'll have to go very quickly. So I think personalized therapy, I think, is something, these are the synonyms of personalized therapy. You can call it stratified medicine, you can call it precision medicine, you can call it targeted treatment. Ultimately, essentially, if where targeted therapy has come of age has been cancer therapy, where you now have molecules which target a particular mutation, starting with imatinib, which has totally revolutionized chronic myeloid leukemia, made it a curable disease, to something like Tarsera or you know, what is it, erlotinib, which has revolutionized therapy for adenocarcinomas which have a particular mutation. But rheumatoid arthritis, we don't have mutations, or rather we have polymorphisms, and but most of our patients don't carry monogenic targetable mutations, right? So essentially, how do we implement targeted therapy for rheumatoid arthritis? So basically, it has been transcriptomics. Rather than looking at gene mutations, it has been mostly looking at the gene expression. So if you look at gene expression, this was one of the first studies. It's been cited almost 300 times in 2014 by Dennis Gonagle et al., who looked at synovial tissue from 49 patients and did a RNA extraction and looked at gene expression by microarray. And this might seem a complicated diagram, but just look at this here. They tried to say that you could separate these tissues into 4 types. These 4 major types were a lymphoid synovial tissue, a myeloid synovial tissue, a low inflammation synovial tissue, or a fibroid synovial tissue. They looked at cells also. I'm not going to go into details due to lack of time. They looked at transcriptomics also, and they suggested 2 biomarkers, which is a lymphoid biomarker CXC motif CXCL13, and a myeloid biomarker which is soluble ICAM1. And they showed, if you look on the left side, is basically the where the ICAM was high and the CXCL13 was low, a myeloid phenotype. And here you see that tocilizumab did much better than adalimumab did much better than tocilizumab, right? Whereas if you look at the other phenotype, which was the at the other end, where ICAM1 was low and CXC13 was high, they responded much better to tocilizumab than adalimumab. So they suggested that there was some extent, there were of course 2 more categories which were much less different, differentiated in terms of response, but essentially they did suggest that you could, to some extent, target therapy based on microanalysis. And this is a study which we all would be kind of aware of. This was one of the first randomized controlled trials which was based on, biopsy driven. So in this trial, basically what they took patients of RA who were refractory, and then they took their synovial biopsy, and based on synovial biopsy histology initially, they randomized them to receive either tocilizumab or rituximab. And their hypothesis was that tocilizumab might be better than rituximab in patients in whom the synovial biopsy shows very little B cells or no B cells at all, which stands to reason because obviously rituximab targets B cells. So what they found is that in the B cell poor, they did find a statistically significant response with tocilizumab, not in the primary outcome, but if you look at the supplementary primary endpoint, there was a statistically significant difference. That is a 50% improvement plus a low disease activity in the B cell poor. And if you look at this was by the histological classification, by the RNA sequencing classification, they found even a better differentiation that these patients respond much better to tocilizumab, the patients who don't have B cells on their histology or by RNA sequencing. However, contrarily, in the B cell rich population, that means the patients whose synovial biopsies had histological B cells or RNA sequencing which showed B cell gene expression, they found that there was no significant difference. Rituximab didn't do better. tocilizumab and rituximab were the same. So to some extent, half-half in terms of win. I'm just have I exceeded my time? I think you said. I'm sorry. I'll just finish the last three. So anything apart from gene expression in the future for targeted therapy? Yes. Single cell RNA sequencing probably could be one way in which we are looking at novel T cell populations, novel fibroblast populations in the synovium, which may be targeted at some stage. So finally, coming back to my last slide, take-home points, which I told you about treat to target, is a very important strategy for us. But probably we have a huge number of choices. We have to all decide personally. That treat to target should not take the focus away from patient medicine. That we become so focused on a target that we forget the patient. And so we have to strike a balance, and as well as we still don't know the large population. So obviously the way forward, that was my topic, has to be a combination of both. And Indian rheumatoid, I don't think any of us believe is any different from rheumatoid arthritis anywhere in the world. And most of us would be are happy to follow Western guidelines, and we find them reasonably. And we would be, I guess, most of us are, the way forward would be both of these done together. Whenever we have personalized medicine, we move to it. Treat to target, obviously, most of us are applying in our practice. Thank you very much.
Thank you, Doctor. Request Dr. Kunihiro Yamaoka from Japan to please take the stage. He will be discussing on the impact of publications on RA from India and the potential international collaborations.
And also the Chief of Scientific Committee, Professor Danta, for inviting me. And also thank you very much for the chairpersons and the kind introduction. I'm very honored to be invited here. So my talk is about impact-making publications on RA from India, which I don't really know what to talk about. It's my first time to come to Iracon, and it's really a pleasure to meet a lot of Indian rheumatologists. And actually, I would talk about the experience in Japan, and I will be short. Just briefly, I will introduce myself. This is a map of Japan. I think you can yeah. So where I come from is right beside Tokyo. This is Tokyo, middle of Japan, and right beside there is called Kanagawa Prefecture. That's right next to Tokyo. I actually live in Tokyo. You can see Mount Fuji. Mount Fuji is right beside the Kanagawa Prefecture. So actually, it's too bad that I can't see Mount Fuji from my hospital. But I think you know this drawing. Have you ever seen this? This is Katsushika Hokusai drawing. It's a very famous wave drawing, but actually you can see the Mount Fuji here. It's a drawing from, looking at the Mount Fuji through the waves. Well, anyway, that's where I come from. I'll briefly touch on, so I did a PubMed search, the impact of publication in rheumatoid arthritis. I don't know what to really talk about, but the left-hand side is the PubMed search on RA in Japan, and the left-hand side. Right-hand side is the PubMed search on rheumatoid arthritis and keyword India. I was quite surprised that the first publication in India came out in 1897, and our first was 1963, and both were like, it wasn't like a review. These authors, Japanese authors, are very famous, a lot of professors. And as you can see, from the 1983, there's a quick rise in our publication. And in the India, there is like in the 1980 something. So it's a quick rise, but still probably the number of publication is different. Probably because of the reason is, I think, well, this is my personal opinion. So if I'm wrong, just correct me. But our Japan College of Rheumatology started in 1957 from approximately like 100 rheumatologists, and now we have like a little bit less than 10,000 rheumatologists. and more than half of them are board certified. So maybe that could be affecting the number of publication. And also, no, let's go ahead. So the experience in Japan is, this left-hand side is something that I just showed you. During this quick rise of publications, what happened is a lot of epidemiologic studies initiated. It's not a national epidemiology study, but it's like a prefecture study, which a lot of cohorts have like 10 to 20,000 of people. And we also participated in a lot of global clinical trials. The good part of participating in these clinical trials is that you will have, as much as you have patients in these clinical trials, you will be able to compare with the ethnicity, also the data of your own people. And what we also did was, we had a lot of biologics, JAK inhibitors approved, and we did an all-case post-marketing surveillance, which means that first 5,000 cases collected every single patient, not one cannot be missed. So that was a very hard work done by the pharmaceutical companies. And what we also did is tapering and discontinuation of biologics. I will briefly touch on that later on. That was something that we first started. And also an array of biologics was approved, and we used to have a drug lag, which was approved very late. It was like 5 to 10 years later than the Western countries. Now it's like 6 months later or something. Maybe in some, like for Olumiant, we were faster than the Western countries. So we now don't barely see drug lag. And also basic and clinical research really went on because we had so many drugs. We put patients on it, and now we have patient samples. So that's how we did all these. Probably it contributed to this publication. And 2003 was the first biologic approval in Japan, which was TNF inhibitors in infliximab. And it was 5 years later after the Western countries. And 2013 was the first JAK inhibitor approval, which was TOFA. So we have really nice drugs. And whenever these two, or maybe the TSD marks were approved, you can see a really quick rise in publications. So I think the development of drug was a important factor. On the right-hand side on the bottom, you can see that I just heard the talk from Dr. Dahir that the T2T is important. Yeah, T2T is important, but how good can we do that? This is, I can't see the numbers, but this is a data from IORA, which is the Tokyo Women's Medical University. They follow like 10,000 patients every single year for more than 20 years. And as you can see, the remission rate has raised up to 55 to 56%, which is somewhat similar in all over the country. But as you can see, for the late 5-something years, it has plateaued. So like Professor Dr. Dahir said, T2T is a limit here. So we can't go up to 100% of remission. So I think this is something that we have to think about. This is the, that I just mentioned, the post-marketing surveillance. Every single case is followed up to 6 months. That's for TOFA as well. This is by Professor Takeuchi's publication, I'm sorry. In the post-marketing surveillance, we found that infliximab had induced tuberculosis in 0.3%, which was quite a surprise for us. So we started to start isoniazid, and with the second TNF inhibitor, we barely saw these tuberculosis. The other thing, so this is in Japanese, so I think I will just go through it quickly. But what I want to emphasize, this is JAK inhibitors. I have been working on JAK, Janus kinase, for like 25 years. And what I want to emphasize is that the single box is a case of cancer who were taking tofa. And the first column shows the first month, second shows the first, next month, third, fourth, fifth, and sixth. So if you look at it, I highlighted in red were the ones that had metastasis at the diagnosis of cancer. So surprisingly, 9 out of 18 cancer cases had metastasis when they were diagnosed as cancer when they were taking JAK inhibitors. But I'm not saying that, I'm not trying to connect to the surveillance study. I'm just saying that the nature of inhibiting JAK has a risk. But we also know that inhibiting TNF has also a risk. So it's a new era, and we have a new mechanism of action. So I'm just trying to emphasize that we have to do something at this point here. So screening is something that we actively do. And now in Japan, I would like to, what is going on in Japan. So as I said, remission, low disease activity have a plateau. T2T approach is limited. I really agree with Dr. Dihira. And the limitation is not, it's a multi-factor. Some patient says they're doing all right, and some physician says, I'm busy to do that. So that has been shown in the Corona study, that has been shown from Western countries, that T2T approach is very, very nice. But it has a limitation, and people sort of come up with reasons not to do it. So, and also precision medicine, personalized medicine, it's really hard to do. Precision medicine, it's still really hard. We have a specific TNF IL-6 inhibitor, but we still don't know which patient should use which one. And maybe the patient background is contributing, and also the TSD-MAR discontinuation, this also failed. We did a lot of trials, and Professor Tanaka from Japan also published numbers of manuscripts for discontinuing, but still it doesn't really work. And we don't know which stage to use JAK inhibitors. We usually use it after methotrexate or after TNF. Depending on the surveillance study, maybe we are going to switch, but my personal opinion, start a good drug early as possible. D2T-RA is something that we have to tackle, and also the last two is something that I would like to emphasize, is that we go to a very high-tech something, sequencing, analyzing, but it doesn't connect to personalized or even precision medicine. So we have to sort of shift our task with the health care professionals other than MDs. That's what's happening, really rapidly happening in Japan. And also we need more patients to be involved in our clinic. So briefly, I would touch on the ACR that I'm in a group called TUNET. I guess you understand it in a different way, but anyway, this is a group that looks into all the abstracts in the ACR and EULAR, and we found that this is a very nice way to diagnose seronegative and seropositive RA. This is looking at DNA methylation, high tech, but this is not really realistic. I mean, in some cases you can actually diagnose, so maybe it's really encouraging, but on the other hand, it's high tech, and when are we going to be able to use it? So why not low tech? This is looking at sputum CCP antibody, and they followed. This is a Dutch study, and they have an early arthritis clinic. So this is a clinic where they follow patients before RA diagnosed. And they looked at sputum, and if the patient had CCP positive in sputum, they had a very high rate of having rheumatoid arthritis as diagnosed. So this can be a very low tech, it's just sputum, it's just collect sputum. And the other thing, this is also something very interesting, and I think I'm collecting these data in Japan. The educational level seems to be involved in inflammatory, the occurrence, developing inflammatory arthritis. So, this was a Dutch study. And you subdivide the patients with low, intermediate, and high education, meaning of the length of education that has been, they have been taking. And this is the occurrence of arthritis. It's not the worsening or the adherence to drugs. It has been published like decades ago that low education is bad for adherence and treatment response. But this is looking at the occurrence of arthritis. So obviously we don't know why this is happening, but low education seems to be something that is affecting the occurrence of arthritis. So why not low tech rather than high tech? Maybe we can do a lot of things without low tech. So my talk was supposed to sort of come up with some ideas with how to collaborate, and I don't really know how everything is going on at Iracon, so maybe I could have some insights during this meeting, and then we'll be really happy to have some discussions. Thank you very much.
Excellent talk, by any question answers?
Expert for tuberculosis, I'm sure all of us use. That led to a product which has now revolutionized the diagnosis of tuberculosis and resistance to first-line therapy. But in RA, we don't have a product which has come in to kind of guide us, which obviously precision medicine is mostly directed towards the expensive drugs, towards the biologics, which biologic to choose, and so in today's world it has to be treat to target, with the caveats which, as Professor Yamamoto also correctly said, that there is a problem, there is a fatigue element which comes in after, or probably as well as the patients have to be really with you to take treat to target to an extreme in some patients who are just not responding.
Second is just wanted to know, so the commonest question once we have the patients are in remission, so when can we stop the drugs? So any idea on that one? So you have treat to target, you have targeted acute remission. So is there any time limit or this one where you want to consider tapering of DMRs? I'm not talking about biological drugs.
I think in general it's 6 months in remission, but it's just in general. And I think if you are in deeper remission, you have the lower risk of flare. So not only remission is not enough. So in terms of DAS28, it's not 2.6 but 1.2. So these are probably the targets that we might want to aim for tapering discontinuity.
Any questions from audience? CP in clinical medicine, is there any relevance of predicting, any relevance of, you showed the NCCC positivity in sputum predicting high risk of arthritis?
Yes.
So is it going to be a reality, or it is still?
So it's a study that probably will go on from now.
Yeah.
It just presented in ACR 2 weeks ago. So I think that it's something really encouraging for us. It's very easy, and it doesn't have to have $1 million machine. So it's really encouraging.
Yes, thank you for the talk. I missed Varun's talk because by the time I came back from another section. The question was, the sputum anti-CCP, do you think these patients would be more likely to have interstitial lung disease in the future because the circulation probably starts in the lung? And
yeah, so that was a discussion that we had when we were making this slide, but we don't actually know. And actually, the interesting part was it was the IgA isotype rather than the IgG.
And you showed in one of your slides increased risk of cancers, metastatic cancer. So is it really a concern for?
So this is not an increase. This is a all post-marketing surveillance of tofacitinib. So it's not comparing with other treatment. It's just that we had 18 cases of cancer in 2018. And out of that, 9 cases had a metastasis. What I'm trying to say is that if you have an active rheumatoid arthritis patient, and most of them were probably treated with other biologics, and they failed, so they use tofacitinib. But when you want to do that, you should at least do something before starting a tofa. I mean, it depends on the situation that you are. If you're in a big hospital, you're in a small clinic, you're in a really suburban place, it's really different. But I'm just trying to say that do something that you can sort of check on your patient and sort of, talk to your patient and be sort of really, sure that this is going to be rather safe.
Okay, thank you. So we
flares, being able to provide services when people need it. So here's a quick analysis that we're doing.